everyone. Thank you so much to the organizers for this opportunity. I wish I was able to join you all in person. Unfortunately, I couldn't make it this time because of an injury, but hopefully we'll get to see you all at another time. Today, I will be walking us through the management for early breast cancer in the community setting. The topic is vast in itself, so for the sake of today's talk, I will focus on the practice-changing updates from last year in this space. This is just a disclaimer and credits for the slides for this presentation. The layout of today's talk, I will start us off with updates on hormone receptor positive breast cancer. Next stop would be triple negative breast cancer, and we will be ending today's talk with HER2 positive breast cancer updates. In the hormone receptor positive breast cancer, we are going to be discussing surgical de-escalation strategies, new treatment updates in the endocrine therapy space, and lastly, CDK4/6 inhibitors. First off, the age-old question of, do all early-stage breast cancer patients need axillary staging? This goes to the very heart of the risk that comes with the notion that more is better. We know that axillary surgery or staging comes with risks of lymphedema, nerve damage, and other complications. So Sound and Enzima trials looked to challenge this paradigm and looked at patient populations with favorable risk profile, patients age 50 or higher, postmenopausal, size 2 or less centimeters, grade 1 or 2, hormone receptor positive breast cancer patients. Based on the results of these trials, ASCO sent an update in 2025 recommending clinicians should not recommend routine sentinel lymph node biopsy in select patients who are postmenopausal and age 50 or higher of age with negative findings on the preoperative axillary ultrasound for grade 1 to 2, small, less than or equal to 2 centimeters, hormone receptor positive, HER2 negative breast cancer who are undergoing breast conservation therapy. Next up, we have the updates from the soft and text studies, which have now for decades continuing to guide our treatment for premenopausal women with hormone receptor positive breast cancer. So this study shows to us that there is a confirmed persistent benefit of ovarian suppression addition to tamoxifen or aromatase inhibitor in patients who are premenopausal. There is an IDFS benefit that is statistically significant. The overall survival trends favor ovarian suppression, but these are not statistically significant. Next up, we are going to be talking about the lidERA study, which is a global randomized open label multi-center phase 3 study, which for the first time showed that we have an oral SERD, which has invasive disease-free survival benefit. For decades, our backbone of treatment for endocrine therapy has been tamoxifen and aromatase inhibitors. This new oral SERD coming into this space and showing to us statistically significant and clinically meaningful improvement in IDFS is our potential newest kid on the block, and is a pretty amazing next option that we now will hopefully be having in the near future. As far as the adverse events profile goes, we can see that there were not really a whole lot of new concerning safety signals that were found here. The drug did have similar side effect profile to some of the other endocrine therapy options we know. There was some lower grade bradycardia and venous thromboembolic events that were noted in the giredestrant patient population. Up next, we're going to be talking about the Monarch E study, which shows the primary overall survival results for the adjuvant abemaciclib plus endocrine therapy in patients with hormone receptor positive, HER2 negative, high risk early breast cancer patients. At a median follow-up of 6.3 years, abemaciclib in combination with endocrine therapy, abemaciclib total duration being 2 years, reduced the risk of death by 15.8% compared to endocrine therapy alone. So this is the first CDK4/6 inhibitor to achieve a statistically significant improvement in overall survival for this particular disease group. Next up, we have updates in the triple negative breast cancer space, where we know that our current standard of care for triple negative breast cancer locally advanced is the Keynote 522 regimen, which has 4 different chemotherapies and pembrolizumab. The clinical trial Scarlet, which is an ongoing study, is looking at anthracycline omission and carboplatin and taxane-based chemotherapy regimen in combination with pembrolizumab, and is currently looking at anthracycline de-escalation strategies. We also have a number of other trials which are looking at other immunotherapy adaptation strategies in this particular subgroup too. These trials are still cooking, but hopefully will give us better strategies for this particular patient population as well. Finally, into the HER2 positive breast cancer space, we are going to be covering today 2 neoadjuvant studies and 1 adjuvant study. First up is the NeoCAR-HP study. So we know that our current standard of care for stage 2 or 3 HER2 positive breast cancer patient includes taxane-based chemotherapy along with HER2-directed therapy with or without carboplatin. This clinical trial is basically looking at the potential omission of carboplatin-based chemotherapy and looking to see what is the efficacy outcome if we were to omit carboplatin. Here, there is primary endpoint results of the pathological complete remission rates, which we can see between the 2 arms, THP versus TCHP, are pretty similar. No surprises on the safety outcomes. Omitting 1 chemotherapy, that is carboplatin, leads to less hematological adverse events, less cytopenias. Same goes for non-hematological adverse events. Dropping carboplatin led to decreased neuropathy, nausea, vomiting, fatigue, and decreased risk of the elevated creatinine. Hence, omission of carboplatin with dual HER2 blockade could be a valuable de-escalated neoadjuvant strategy for patients with HER2-positive early breast cancer. Next up, Destiny Breast 11. This is a randomized global multi-center open-label phase 3 study which had 3 neoadjuvant treatment arms: TDXD, 4 cycles followed by 4 cycles of THP. Second arm, dose dense AC, 4 cycles followed by THP, 4 cycles. Third arm, TDXD, 8 cycles. TDXD arm was closed per the IDMC recommendations. These patients then went on to receive surgery and then received the standard of care adjuvant treatment. The primary endpoint for this study was pathological complete remission. The study results here show that after surgery, 81.3% of the patients who received TDXD followed by THP had no or minimal residual invasive cancer, RCB 0 or 1, detected in the resected breast or lymph node tissue, versus 69.1% in patients who received dose dense AC followed by THP. almost 80% of patients with the hormone receptor positive disease had RCB 0 or 1 with the TDXD THP arm. So the event-free survival here is immature, but is showing a favorable trend here. This shows the overall safety summary. We saw that TDXD THP was favorable when compared to dose-dense AC-THP with reduced rates of grade 3 or higher adverse events, serious AEs, treatment interruptions, and left ventricular dysfunction and ILD were low and were pretty similar between the two arms. Conclusion, more than 2/3 of the patients in the TDXD THP arm had a pathological complete remission. This treatment regimen has been FDA approved in China, but is currently still pending its approval in the US. So TBD there. Finally, on to the Destiny Breast 05 study, global, multi-center, randomized, open-label, phase 3 clinical trial, which had a pretty stringent criteria. It looked to select high-risk patients defined as the presentation prior to the neoadjuvant treatment. So this had two buckets. One, inoperable early breast cancer patients with CT4 or node positive breast cancer, patients with operable breast cancer who were CT1 to 3 and 0 to 1 with axillary node positive disease after neoadjuvant treatment. These are all patients with HER2 positive breast cancer. All of these patients received neoadjuvant chemotherapy along with HER2 directed therapy. They went on to receive standard of care surgery and then were randomized into two groups, standard of care TDM1 every 3 weeks, 14 cycles, arm 2 TDXD every 3 weeks, 14 cycles. The primary endpoint here was invasive disease-free survival. Just taking a quick look at the baseline demographics and clinical characteristics here, 71% of the patients in both arms almost were hormone receptor positive breast cancer patients. Half of the patients in both groups ended up receiving anthracyclines, and interestingly, half of the patients received concurrent radiotherapy here. The results. Lower distal and locoregional recurrences were observed with TDXD versus TDM1, including CNS recurrences. So very impressive data in this space. We know that the HER2 positive breast cancer patients, especially those that were having residual disease, even after they were continuing to get TDM1, there is a pretty high risk of CNS recurrences. And in this space, having a drug which is more efficacious gives us better chances of preventing CNS recurrence is so impressive. It is so great to have drugs in this space, which are giving us great results in the CNS as well. This is an area of unmet need, and it's great to see results as these. Looking into the overall summary, so TDXD was associated with higher drug-related ILD and pneumonitis risk compared to TDM1. This is a very, very important side effect to bear in mind, even in patients who are showing us imaging-related ILD findings, or in patients who are having even minor symptoms, respiratory symptoms. We should have a low threshold to make sure we are looking for this particular side effect. But the interesting thing here, even with the concurrent radiotherapy that the patient received in the adjuvant context, ILD and pneumonitis were noted, but these were not super horrible numbers, but just to bear that in mind. Bottom line, adjuvant T-DXd demonstrated superior efficacy with a manageable safety in patients with high-risk HER2-positive early breast cancer, representing a new standard of care in this post-neoadjuvant setting. This led to the FDA approval and NCCN Category 1 addition for the use of adjuvant T-DXd or Enhertu or trastuzumab deruxtecan in this particular category. Summary. Today, we spoke about escalation strategies, the use of adjuvant CDK4/6 inhibitors. Now, abemaciclib has OS benefit. We looked at different de-escalation approaches. We learned more is not better. The NeoCAR HP study showing carboplatin omission in HER2-positive breast cancer, surgical de-escalation in low-risk hormone receptor-positive breast cancer, growing evidence that platinum will obviate the need for anthracyclines, perhaps someday in the triple-negative breast cancer space. ADCs for HER2-positive breast cancer, T-DXd is now approved in the adjuvant setting and seems to be making its way into the neoadjuvant space. I did not get a chance today to talk about the ctDNA-guided surveillance and intervention strategies, but these trials are underway and the treatment landscape is ever evolving. And that is it from me for today. Just wanted again to say thank you to the organizers and just a shout out to Houston. It was my first home, my first training institution for residency was here. My first rotation was at MD Anderson. So very, very indebted to all my mentors that I have had along the way. Hopefully you guys have a chance to enjoy some good Houston hospitality and Houston food. That is all that I have for today. Wish you all a good day ahead. Bye.